In this video, I will be demonstrating how I went about performing a Phaco in a fairly almost hypermature cataract with a hard nucleus. So here initially after staining the capsule, I am going ahead and initiating my rexus and with my 26 gauge needle, having a little bit of difficulty, and there you can see the cortex has egressed out. I do not aspirate this cortex, I just tamponade it with further amounts of HPMC. Now taking my Uthrata, I plan to complete this rexus. The cortex keeps coming out, however I am able to see the edge with the help of further tamponade of the opening with 2% HPMC. And that's it. Take the Uthrata again and complete the rexus. Not an ideal rexus, probably a little bit on the smaller side. And you do not need any hydrodissection in this case. Take my sharp chopper in my left hand and the Phaco in the right, and you can see the nucleus is pretty hard. So I'm at 80% power, 400 millimeters of vacuum, 40 ml flow rate, and I am at in continuous mode. So this is my preferred method of nuclear disassembly using this woodcutter's chopping technique, and look, it works beautifully. That's a complete chop. Yes, I do not expect it to go all the way through. However, this is fairly adequate. So I'm now trying to rotate it 180. Didn't actually go completely 180. That's okay. And look at this chop. As long as you can see the posterior capsule, when you laterally separate, the chop is a good chop. There are some fibers attached in the center. Doesn't matter, we can handle that later. So my plan is to make at least 4 segments of 5 to 6 at the most. Don't make too many. This is a very mobile nucleus, so you don't want too many pieces flying around. So the whole idea here, although this is a big piece, I decide let me handle the heminucleus first, and not exactly in the center of the heminucleus. That's because you just cannot control this movement of this nucleus. So I decide to take off the smaller piece rather than it flying around. I then target this, and now look, it's difficult to control this tilt. So I start eating up this, just tilt it a bit, target that apex and start eating, and that's it. So my main aim here is not to allow pieces to fly around in the anterior chamber, hitting the endothelium. And mind you, I haven't reduced the vacuum, I haven't reduced the flow rate. I am at the same continuous power of Phaco. This last piece is a little bit big, so I stabilize it with my chopper by digging into it and making it into 2 pieces. Before it separates, I eat off one and then target the other. This is how you have to control your Phaco emulsification and not allow the pieces to fly around. Now once that hard part is done, there are only few cortical fibers, so you have to be a little bit careful here when you're aspirating, because this capsule may not be very stable, this bag may not be very stable. Moreover, both the anterior and posterior capsule can be quite close to each other, so there is a danger of engaging the posterior capsule as well, other than zonular dialysis. Look at the posterior capsule, how it is flaying around, and there are some fibers sticking onto it. So I go with my vacuum mode. You have to be very careful with this step. I take out as much as possible, as much as is safely possible to remove, and then I sort of almost polish off the rest with my visco cannula. This is a very effective technique. Just scrape it off the posterior capsule. Most of it comes off very easily, and it's a very safe technique. That's the main thing. Once that's done, I go ahead and place my single piece hydrophobic IOL into the bag initially. That is, the leading haptic goes into the bag. I just put in some HPMC, and with my dialer help the trailing haptic as well. It's a small rexus, as you know, and so it needs a little bit of help to go into the bag, and that's neatly done. And these are just the finishing touches. Remove the HPMC, put in your intracameral antibiotic, check the wounds, and you're good to conclude the surgery. Thank you so much for watching.